In this module, I'll be speaking on the surgical steps in intraocular lens exchange. So when is an intraocular lens exchange needed? When faced with a refractive surprise, use the Barrett treatment formula to determine the appropriate sphere and toric power of the specified IOL model and the optimal alignment, and decide if IOL exchange is needed. Do note that AestheticMedicineFix.com addresses only angular errors seen in toric misalignment and does not solve refractive errors encountered in miscalculation or wrong IOL. Plan for IOL exchange as soon as possible. However, if you're dealing with the unhappy multifocal patient, allow 6 months for neuroadaptation to develop and do not do a YAG capsulotomy. Use pseudophakic mode to acquire biometry without prior history. Now check the IOL model, the integrity of the posterior capsule, the capsulorhexis and the zonules. Have the appropriate intraocular lens and a 3-piece intraocular lens on standby. Ensure that appropriate instruments, anterior vitrectomy and triamcinolone acetonide for staining vitreous are available. You can refer to the steps to toric rotation for marking of reference and toric axes. To mobilize the intraocular lens, inject retentive viscoelastic into the space between the capsule and the intraocular lens. This may be difficult if this is being done more than a month after surgery. You may need a second instrument to help you to pick up that lens capsule edge before slipping the cannula of the viscoelastic under that capsule. Use a Sinskey hook to nudge and to free up the intraocular lens. Mobilize the IOL especially in areas of strong adhesion such as the knob at the end of the haptic or positioning holes, because fibrosis may have grown through these holes to strongly cause adhesion between the anterior and posterior capsules. If there's any fibrosis around the haptics, do be careful to dissect this with scissors and do not yank the lens if it's adherent, because you may lose zonules. Open up the capsular bag adequately to facilitate IOL rotation. Use IOL grasping forceps and a 21 gauge micro scissors, or you may even use Varner scissors if you do not have these specialized scissors. A completely freed intraocular lens may be brought into the anterior chamber, cut and removed. When the haptics are not completely freed, anteriorize the optic and cut the optic into 3 pieces, removing the center piece first. Now that space has been created, the haptics can be freely tackled after further dissection. The intraocular lens may be removed by cutting into 2 or 3 pieces, and of course if you cut into 2 pieces, basically you have to have a larger incision, at least 2.75 mm, and if you cut into 3 pieces, you can reduce that size to 2.2 mm. This is just to show you how you may explant an intraocular lens that's been completely freed up and positioned in the anterior chamber by folding and explanting. So what you need is actually instruments such as a cyclodialysis spatula, or in this case I'm using Kelman-McPherson forceps to come in from a paracentesis across from the incision, and that actually supports the intraocular lens whilst you place a lens holding forceps into the main incision. And while you're supporting the lens, you press down with your forceps to fold the lens, and you need to try to do this as symmetrically as possible. And as the lens begins to fold, you then retract this instrument that comes in across from the main incision, and you then slowly maneuver this lens out of the eye. Now you must not try this with a silicone lens because it's too slippery to allow folding within the eye. This is another technique which perhaps is more commonly used, and it's technically simpler to use. So you want to completely free up the lens, and then you cut the lens either into half, as is seen in this left diagram here, and in the right you can cut it into 3 pieces, and then you explant it. Now, in the case where you're trying to release the lens and you find that it's rather adherent and you're not able to completely free up the haptics, do not panic, right? So once you inject viscoelastic under the optic, you bring that forwards in front of the capsulorhexis, you then cut across into 3 pieces and you remove the centerpiece of the optic. And once you've done that, you'll realize there's a lot more space for you to maneuver the remnant parts of the intraocular lens. You can then take your time to use viscoelastic or forceps to dissect free the haptic without stressing the capsular rim and the zonules. And step by step, you can remove the other pieces. Now, very commonly, I use a modified technique of the Phaik style explantation of the IOL. Now, in the original description of this technique, we actually remove a quarter of the lens so that creates space for you to rotate the lens out without having to transect the lens completely. What I do, as you can see here with the first diagram, I cut across almost to the end of the optic, and then I pull out one half, and as this half comes through the incision, I rotate the half of the optic around so that the other half follows without hitting the angle and damaging the structures within the eye. And in this way, we do not actually have to pull out two pieces separately because they come along together. Now, in this other technique called the IOL scaffold technique, which has been recently described, we are using the lens that we're going to exchange to really provide a scaffold and a protection for the posterior capsule of this eye. So after freeing up the lens that you wish to explant and that's brought into the anterior chamber that's filled with dispersive viscoelastic, we inject adequate viscoelastic into the bag, and then we inject the intraocular lens behind the first lens that you want to explant. So this now in position acts as a scaffold whilst you cut across the lens that you wish to explant. And this can be done safely because your scissors will never hit the posterior capsule, which is now protected by the new intraocular lens. Sometimes you can put this lens in the sulcus and then manipulate it later into the capsular bag. It does not have to be in the final position when you first inject it into the eye. So in summary, exchange the intraocular lens based on a Barrett treatment formula. This is probably the most accurate that we have today. And you want to do this early rather than late. You want to avoid a YAG capsulotomy prior to explantation, especially if you're dealing with a multifocal lens and you're not sure that the patient is really happy and maybe intending to have an exchange. Mobilize the optic followed by the haptics with retentive viscoelastic and micro instruments. Cut the optic into 2 or 3 pieces. This is really the simplest technique. And then you remove it over a bed of viscoelastic. Remove the viscoelastic from under the new IOL and position appropriately. Thank you for your attention.